It's a pleasure to be talking with all of you. You know, it's interesting when I did my very first training for the McV home visiting staff. Uh, it was titled Identifying and Intervening in Risk. It's all about relationships. So, from the very beginning of McV, we have stressed the importance of relationships in working with this population of women. And as we go forward today, you'll see that the way, at least, that we think about the home visitors and the work they're doing, we couch it in the context of relationships. Now, the purpose of today's webinar is to look at some of the issues that the home visitors are dealing with and talk about ways in which all of you, as infant mental health specialists, can provide technical assistance and support to them. I'm sure all of you are familiar with the 4-Piece Plus form. This is the screening form that screens pregnant and postpartum women for alcohol, tobacco, and illicit drug use, domestic violence, and depression. And I think that all of you have been on webinars previously and very familiar with this form and the structure of the screening interview. The important point to remember as we've worked with the McV home visiting staff is that the this is not one of those check-off screening forms that you ask a question and check off the answer. This is really a tool for engagement. And what we stress with the home visitors is that they make this a conversation between them and the woman, so that often what they find as they go through this, asking these questions and talking with the woman about them, the women just open up, and the screening form isn't really necessary. It just provides a structure for carrying on the conversation. Now, with that in mind, what I want to do today is talk about your field of expertise, infant mental health, and how it applies to some of the questions and difficulties that have come up for the home visitors. And this slide is nothing new for any of you. It is the basic concept of attachment. Attachment is the interconnectedness between human beings. But the point I want to emphasize, and here's where the home visitors run into some difficulties, is that appropriate attachment between a mother and her infant requires two steps. First of all, both mother and child must be able to read each other's cues. And secondly, they must be able to respond appropriately to each other's cues. And when substance abuse, alcohol, tobacco, or illicit drug use is involved, this interconnectedness fails, because a woman affected by drugs is unable to read her infant's cues, and an infant affected by prenatal exposure is unable to read his mother's cues. So that's what we're going to talk about today. Now, to get us started, to understand this concept of interconnectedness and the importance of reading and responding to cues, I want to review something I've talked about in previous webinars, but this model for information processing. There are 4 steps or 4 domains of information processing. And by information processing, I mean the way a human takes information into the brain, uses it, and then translates it so that it can guide appropriate behavior and responses. And there are 4 steps. First, there's input, that is the information coming into the brain. The next step is integration, that is organizing and interpreting the input. The third step is memory, storing that information in memory for later use. And the final step is output, when the time is appropriate, using the input to guide your behavior. So those are the 4 steps of information processing. Now, something I'm sure you're all familiar with, the brain, and the front of the brain is to your left. You can see the frontal lobe. the parietal lobe toward the back, the occipital lobe at the very back of the brain, the cerebellum, and the temporal lobe. Now, these are the main components or areas of the brain. And a very important area right up front called the prefrontal cortex. And the prefrontal cortex is the regulatory center of the brain. Now, you don't have to memorize the parts of the brain, but what is important for you to understand is that as you bring information into the brain, it travels along different pathways. So visual information, obviously, enters the eye, travels along the optic nerve until it hits the back of the brain, the occipital lobe, and this is called the visual cortex. So visual information enters the back of the brain. Auditory information, that is what you hear, enters the ear, travels along the 8th cranial nerve, the auditory nerve, and inserts on the midline of the brain. And then taste, touch, and smell enter through the top part of the brain, the parietal lobe. So the important point here is that depending on what kind of information it is, it travels along different pathways to enter the brain. So now the brain must bring that information together, and that's integration. And I'm sure all of you have heard of sensory integration. That is the ability to bring this sensory information from different directions into a coherent whole and then store it as perceptions and memories in the back of the brain. And then when it's time to use the information that's stored in the back of the brain, it shoots forward to the prefrontal cortex. And the prefrontal cortex, as I said, is the regulatory center of the brain. It contains dopamine, and dopamine fires off based on the information that's passed forward to the prefrontal cortex. Dopamine fires off and tells you how to regulate your behaviors and your responses in response to the information that you brought into the brain. So that's the basic concept of information processing. Now, as we talk about attachment and the relationship between mother and child, we're going to start with talking about the mother and the factors that interfere with information processing. And this comes down to the maternal-fetal relationship and the maternal-infant relationship. Now, as we have studied women who have used alcohol, tobacco, illicit drugs over the years, we have found there are 5 basic factors that affect the relationships that a chemically dependent woman can have. The first is negative heritage, that is her family history. The second is the emotional instability in her life, lack of social support, her cognitive functioning, and her psychological functioning. So these are the 5 factors, and we're going to talk about each of these individually. Now, the best study of the negative heritage that many adults bring with them into adulthood is the ACEs study, the Adverse Childhood Experiences Study. This was conducted at Kaiser Permanente a couple of decades ago, and what they looked at was the kind of experiences an individual had as a young child that affected that individual's health as he grew older. And what they were able to do at Kaiser is go back into the records of adults who were at least 50 years old. And so what they looked at is the kinds of experiences they had as children. And what the Kaiser study found was that if an individual as a child had recurrent and severe emotional abuse, physical abuse, contact sexual abuse, or grew up in a home where there was an alcoholic or drug user, a family member in prison, any mental illness in the household, or neither biological parent was present, so that includes foster and adopted children, then 50 years later, those early psychosocial experiences translated into organic disease. And this was quite profound because they found that the more of these types of experiences the individual had as a child, the higher the risk for heart disease, cardiovascular disease, high blood pressure, strokes, diabetes. So the list went on and on and on. And what they emphasize in this study, and what this study tells us, is that these experiences as children affect your life long term. Now, pertinent to this, I want to tell you about some women that we've studied. Now, these are all, I'm going to tell you about 75 pregnant women who were enrolled in one of our treatment programs, all of whom were pregnant, 18 years and older, and all of whom were actively using drugs during the pregnancy. And we're going to compare them to a matched group of women from the same area of Chicago, the Cabrini Green, Robert Taylor Homes, that inner city area of Chicago. 60 women who also were pregnant, 18 years and older, had grown up in Cabrini Green, but they've never used drugs. And we're going to look at the life backgrounds, the childhood experiences for these two groups of women. They were similar for age, race, mean income. They were all well below poverty level, and average education. They averaged about 11 years of education. Now, when we look at the family history, we see that the history of the women in the drug using group, the history of their fathers having drug and alcohol problems, that rate is fairly similar. It is not statistically different from the rate of the women in the non-drug using group. But as you can see from this slide, where the difference really lay was in their mother's history. And you can see significantly more women in the drug using group had a mother with alcohol problems or drug problems as compared to the non-using group. So maternal use of alcohol and drugs for these women was a key factor that put them on the path toward alcohol and drug use. Now, their pregnancy histories, you can see, look at the 16 to 19-year-old age range, and you see that a significant number of women in both groups had adolescent pregnancies. But where the difference was, if you look at the early adolescent pregnancy line, that is, their first pregnancy was at less than 15 years of age, you can see a statistically significant difference in the percentage of women, with the women in the drug using group having significantly higher rates of early adolescent pregnancy. Now, the question was this pregnancy planned? Neither group did very well there. And both groups had an average number of children, 1.3 for the non-drug using, 2.4 for the drug using. So what this tells us is the women in the drug using group had previous children prior to this pregnancy. But the important point was most of those women, their children had already been moved from them by DCFS due to the women's ongoing drug use. So they have lost their previous children. Now think about that and the connotations for the relationship with this child that she's pregnant with now. Now for the drug using women, here's another important point, and this is certainly what we're finding from the McVie data, is the high rate of polydrug use. Now, one of the differences between men and women when it comes to substance abuse is that women are polydrug users. Men will use one substance. Women, for both social and economic reasons, use multiple substances. And so, although the women in this group, the majority of them were using cocaine as their primary drug, 81% of all women were using alcohol. And that's the important point here. I know that we often pay a lot of attention to methamphetamine users, cocaine users, heroin users. The reality is, and this is borne out in the McVie data, the drug of most common use among pregnant women enrolled in McVie is alcohol. And it's often paired with other drugs, but alcohol is by far the most common drug the women are using. Now, for the population under study here, what was the age that they first began using? You can see that the first alcohol use was at about 15 years, and the first illicit drug use was at about 17 years. But look at the age range, and you can see that some of these women started using at 8 to 9 years of age. Now, at the time we were doing these studies here in Chicago, we were brought into North Carolina and asked by the governor's office there to evaluate their treatment programs and the state of treatment for women and pregnant women in North Carolina. And so I had an opportunity during this same period to travel to North Carolina to interview professionals as well as women enrolled in substance abuse. And what we found in our work in North Carolina was a number of women who talked to us about their first cocaine use being at 5 years of age. Now, we were pretty shocked, but we brought that data back to Chicago and combined the North Carolina and the Chicago data to try to see what was going on. And what we found is that if any woman tells you that her first drug or alcohol use was prior to the age of about 11 years, what do you know happened? In every case, the woman had been molested at the time of her first drug or alcohol use. So the situation was, when it came down to it, was at a very young age, the perpetrator got her high or drunk and then molested her. Now, think what that's going to do for a woman who now, years later, is pregnant and has a child, her own history of molestation and that sexual trauma. How is that going to affect her relationship and how she perceives this new baby that she's just had? Now, within the context of drug use history, you can see the longest abstinence that any of these women had put together was on average 115 days, which is about 3 months. So what that means, now if you remember, the women in the drug using group average age was about 28 years. So for about the past 10 years, the longest any of the women had been drug or alcohol free was about 3 months. Although the majority of them had been in treatment before, this just points out addiction is a chronic relapsing disease. And that's why it's so important that the home visitors on the very front line identify women at risk for substance abuse and get them into treatment. Because if they don't, not only this baby, but all the women's future babies will be affected. The second area is emotional instability. And as we looked at our data, we found that this emotional instability was most related to the women's horrific history of trauma. Looking at the drug-using women, 38% of them had a history of domestic violence, with 50% of them having been physically abused during the current pregnancy. And just as a side note, you realize that a woman in her lifetime is most likely to be murdered when she's pregnant or with 1 year after delivery. So this is a very dangerous time for these women, which is why, again, we have to be very careful in screening women for domestic violence, because if we do this incorrectly, or if we push the woman too hard, we can put her in greater danger. And so the clinicians, the home visitors, do need support and guidance as they're working with domestic violence issues. Sexual abuse, 33% of the drug-using women had histories of sexual abuse, 44% had been raped, and 30% had lost a loved one to a violent death. And what this tells us is that these women's history of trauma must be addressed through the therapeutic process. Now, you look at these data and you can almost understand why the women are using drugs. Drugs are a painkiller. So the question on this slide is not why are the women using drugs? It's why the second group isn't using drugs. Now, look at that group, the non-drug using group. Remember, this is a match control set of women recruited from Cabrini Green, Robert Taylor Homes, and they have pretty significant histories of violence. 15% of the non-using women had a history of domestic violence, 17% had been physically abused during the current pregnancy, 12% sexual abuse, 12% rape, and 22% loss of a loved one to a violent death. So these women have a pretty significant history of violence and trauma themselves. So the question comes down, why aren't they using? We studied that, and interestingly, especially from your perspective, what the answer came down to, what differentiated these two groups of women, essentially what protected the non-drug using group of women from moving toward no use of drugs, that protective factor was attachment. Now, when I'm talking to other groups, they find this quite shocking. They think about school programs, they think about prevention programs in the community. No one ever really comes down and realizes that the whole basis of protection for an individual growing up long term are those early childhood attachments. And I know in speaking with all of you, this is almost a given. But childhood attachment, folks out there don't understand what we mean when we talk about attachment. Now, as part of our study, we did look at these women. Now, this aspect, of course, was retrospective. That is, we asked them to recall experiences from their childhood. And we had a 2-page questionnaire, but I'm just going to give you some examples of the questions. Do you remember as a child being told that you were worthless? 61% of the drug-using women could talk about a specific time in their childhood when someone had told them, and it was usually their mother, had told them that they were worthless. 67% of the women, when we asked the question, do you remember as a child feeling unwanted or unloved? 67% of the drug-using women with no cues, no prompts, would talk about a time growing up when someone, again, usually their mother, said, I wish you had never been born. Now that's a pretty profound statement for a young child to hear. As a child, how close did you feel to your mother? Very close, somewhat close, distant, very distant. 28% of the drug-using women felt very close, 32% felt very distant. Now, take those numbers and look at the next column, the non-drug using women, and you can see the remarkable difference. 13% had been told they were worthless, 15% unwanted or unloved, but 62% felt very close, and 5% felt very distant from their mother. So what you see here is that support system, that attachment in early childhood, was present for the majority of the women in the non-using group. But there still was a question. If, you can look at this column and you see that although the non-using women had much, more positive childhoods, it wasn't perfect. With high rates of the women, relative to a typical population, high rates of the women not getting much support from their mothers. And so who do you think the second most important attachment figure was? If the mother failed in that attachment, who was the second most important attachment figure that the women in the non-drug using group named? Now, a lot of people say grandma. Grandma was number 3. The second most important attachment figure was a teacher. And this is where the schools come in. And when I talk with schools, this is what I emphasize to them. Yes, they're there to teach academics, but children look to their teachers, to school personnel, as a positive support system, as a positive role model. And more teachers and more school personnel need to understand the importance of childhood attachment. The third area is lack of social support. A child growing up isolated is going to grow into an adult who's socially isolated. And when we asked these questions, we found that the person as an adult, the person that is still the primary support system for the women, is their mother. And that's the key line there. 39% of the drug using women, but as compared to 63% of the non-using women could rely on their mother. And a great screening question to ask a new mother is, who's going to help you with your baby? And if a woman can't name at least 3 people who are going to help her with her baby, you have a high risk situation, because women need other women to support them. A fourth area is cognitive functioning. Now, the easiest way to assess this is by looking at global IQ, but that doesn't really give you a true picture. There is no statistical difference between mean IQs for these two groups of women. However, when we go beyond cognitive and think more of neurocognitive functioning, that is how the women are using information, it comes down to a different matter. Now, these are MRIs, and we're looking from the back of the brain forward. And the 2 MRIs on your left, the top one where I've got the arrow pointing now, and the bottom one, are a normal adult woman. On your right, top and bottom, are an adult alcoholic woman. So this is a woman with a history of chronic alcoholism. Now, the cuts between these 2 brains are the same, the 2 brains on the top. So if you look at this brain of the normal woman and this brain of the alcoholic woman, you see that the ventricles in the alcoholic woman are much, much larger. Now, the ventricles are an empty space in the middle, in the central part of the brain. You can see them here on the left, the normal size, and they carry the spinal fluid for nutrition to the brain cells. But what you see on the right is that these have expanded. And the reason they have is because alcohol kills brain cells. And what's happened is the brain cells surrounding the ventricles have died off. And so the ventricles have expanded. And this affects global cognitive functioning. Now, if you look at the bottom 2, here on the left is the normal adult woman. And if you look at this structure right here where the arrow is pointing, it looks like a U. This is the corpus callosum. And the corpus callosum is the connection between the left and the right sides of the brain. This is how you transmit information from one side of the brain to the other. On your right is the alcoholic woman. And if you look, first of all, this is the same woman, so of course you see the enlarged ventricles, but look at the corpus callosum. You can see how thinned out this is, and in fact, this is called thinning of the corpus callosum. And what that does is that thinning of the corpus callosum caused by chronic alcohol use, this interferes with transmission of information between one side of the brain and the other. So what you get here is a woman who is not able to take information and use it appropriately. A good example of that is a woman you have a 4 o'clock appointment with. A home visitor goes to the home, knocks on the door, and of course the woman's not there. And the home visitor waits around and finds that the woman shows up finally around 4:45. And the home visitor says, "What time is it?" And the woman says, 4:45. And she says, "Well, what time was your appointment?" And the woman says, 4 o'clock. So cognitively, she knew that the visit was at 4 o'clock. But to take that information, the visit's at 4 o'clock, and move it to a higher regulatory level, that is, move it toward the prefrontal cortex, so that you can use the information to regulate your behavior, so that you can prepare and be at the appointment at 4 o'clock. Information must pass across the corpus callosum. And this is the problem that the home visitors face with the women they're working with so often. It's not that they're late to their appointments because they don't care. It's because they don't have the executive functioning capabilities to plan and complete a task. And much of this is due to this thinning of the corpus callosum with interference of information passing from one side of the brain to the next. And so you're going to need to help the home visitors understand that they can't take these kinds of things personally, but they have to understand that women who have used alcohol and drugs have damage to the brain that affects the way they can function. Academically, there's really no difference between the two groups. What's important to note is on the ABLE, the language portion, that's a reading test. And what this tells you is how well an individual can read and understand what they're reading. And you can see that although the women were in average 11th grade, they could only comprehend what they were reading at about a 7th grade level, which tells us that if you're going to develop written materials, they need to be developed around the 5th to 6th grade level for people to be able to understand them. And the final area is psychological functioning. Another major difference between men and women is that women who use drugs have a significantly higher rate of co-occurring mental health disorders. And the two most common diagnoses we find in working with women who have histories of substance abuse, the two most common diagnoses are depression and borderline personality. Now, borderline personality is someone who is very egocentric. That is, they see everything that happens in the world around them in the context of how that affects them. They have difficulty empathizing and sympathizing with others. Now, think about it. If you have a woman with a history of substance abuse who is depressed and has a borderline personality, how is she going to be able to interact as a pregnant woman or as a new mother? And if a home visitor is trying to work with that woman, she's going to find she has difficulty developing a relationship with the woman. And it's a matter of over time developing that trust. And so the important thing to emphasize as you're working with the home visitors and providing them support and technical assistance, that this is all about relationships. And although typically we think of relationships as relatively easy, and we turn to one another and we look one another in the eye and we build these relationships, there's a sense of trust, that's not what the majority of women enrolled in McV, that's not the background they come from. And many of them, we're finding, 20 to 25%, have histories of substance abuse. And so the home visitors sometimes are getting frustrated that they don't feel like they're really getting across to the woman. And this is where they're going to need a lot of support. So as we look at the women and they're ready to move into a caregiver role with their new baby, they must be responsive and they must be accessible to their infant. And I don't think that that's anything new. Everyone understands and recognizes that. However, what often is left out of the equation is the realization that the infant also must be responsive and must be accessible to his mother. Because as we said in the very beginning, attachment is a two-way street. And both the infant and the mother must be able to read each other's cues and respond appropriately to those cues. And so what we're going to talk about now is the infant who's been exposed to drugs or alcohol and how ready that infant is to read cues and to respond to cues. Now, to talk about the infant's readiness for attachment, let's go back to the very basic biology of drugs. Now, normally, this is the way your nervous system works. If you want, for example, your fingers to wiggle, you send an electrical message from your brain to your fingers to wiggle. Now, there's not one long nerve, but it's a series of nerves, and that electrical message must move along the nerve pathway to reach the end of the nerve, and then must move across the nerve gap to get to the next nerve in order to be transmitted appropriately. And the way that this electrical impulse is transmitted across the nerve gap is through the catecholamine system. Catecholamines are also known as neurotransmitters. Nerve transmitters. And so what they're doing, their responsibility is to transmit electrical impulses across the nerve gap. Now, you're familiar with the neurotransmitters. There's dopamine, serotonin, norepinephrine. I've already mentioned dopamine today because that is the key neurotransmitter involved in substance abuse. So what happens under normal circumstances is the electrical message travels along the nerve pathway, reaches the end of the nerve, the dopamine picks it up and carries it across, releases it, and then dopamine circulates back to the first nerve ending to be stored there again, ready for the next impulse. And that's why you never run out of dopamine, because it's this cycle of release and reuptake. This is called dopamine reuptake. Now, as I said, dopamine is the regulatory center of the brain, but it's also the pleasure center. So when you eat food, your dopamine levels go up. When you exercise, your dopamine levels go up. When you smoke a cigarette, your dopamine levels go up. Because dopamine, as the pleasure center, that's what drug addicts are seeking, is that dopamine stimulation. So let me give you an example. If an individual, in this case a pregnant woman, is using methamphetamine, methamphetamine causes excess release of dopamine across the nerve ending. And so you get a large supply of dopamine at the distal nerve ending, and that's what produces the high. Cocaine acts differently. There's a normal amount of dopamine that crosses the nerve ending, but as the dopamine circulates back, cocaine blocks dopamine reuptake. And so the dopamine stays at this distal nerve ending, and you get the high. And that's the whole process of how drugs give you a high, is they release or they block dopamine. And tobacco, any drug you can name, affects dopamine function. Now, dopamine, in addition to producing the high, has side effects because dopamine acts directly on smooth muscle. And the uterus is all smooth muscle. So when a woman smokes a cigarette or takes cocaine or methamphetamine, it causes contraction of the uterus. And that's why there is an increased rate of preterm labor in women who smoke cigarettes or use drugs. There's also growth retardation of the infants. The fetus doesn't grow normally in utero because dopamine acting on smooth muscle acts on the smooth muscle that surrounds the arteries. And all arteries in the body are surrounded by smooth muscle, including the umbilical arteries. So when a woman smokes a cigarette or uses cocaine or methamphetamine or heroin, whatever drug you want to name, it causes constriction of the smooth muscle around the umbilical arteries so that blood flow doesn't get across to the fetus. And of course, without adequate blood flow, the fetus doesn't grow. And then finally, abruptio placenta. Because dopamine has such effect on the vasculature by causing this constriction of the blood vessels, and because the heart also is smooth muscle, an individual who takes any of these drugs, tobacco, cocaine, methamphetamine, heroin, one of the first effects is rapid heartbeat. So you get tachycardia, a rapid heartbeat, along with vasoconstriction, you are now cutting off blood supply to all parts of the body, including the placenta. And so you get abruptio placenta, the separation of the placenta from the wall of the uterus before the baby is born. And of course, there's a very high rate of infant morbidity and mortality associated with that. Now, this is a picture of a growth impaired baby. And this is one of the pictures in the I Am Concerned book, because you can see how small that baby is. Now, animal studies have shown the same thing. These are two baby rat pups. The pup on your right was born to a mother who said no, she did not take any drugs. The baby pup on your left was born to a mother who used cocaine, was given cocaine by the researchers. And you can see the significant growth impairment in the baby rat on the left. And in addition, on autopsy, the cocaine-exposed rat had a significantly smaller brain size than in proportion to body size than did the rat on the right. Now, we've done these studies in humans. Of course, we can't line pregnant women up and say, okay, you take crack and you don't, you take methamphetamine and you don't. And so we have to rely on statistics. So in a very large population of women who had used drugs during pregnancy, when we asked the question, what drugs are most dangerous as far as infant outcome, for example, birth weight, what drug do you think was number one? It was, in fact, tobacco. Tobacco has a statistically 3 times greater impact than cocaine on predicting low birth weight. And this is because nicotine interferes with dopamine, its functioning, so that you get excess dopamine causing vasoconstriction, but nicotine from tobacco smoke stays at steady levels. Smokers smoke constantly. And so you get a constant impairment of blood flow across the placenta, as compared to cocaine or methamphetamine, which is used intermittently. So the important thing here, and this is another factor that the home visitors have trouble with, tobacco is a substance of abuse. And many of them, interestingly, are more comfortable talking with their clients about cocaine or methamphetamine use than they are in talking about tobacco use. So again, this is another point that they need support with. Now, if you look at the newborn infant, our discussion leads you to understanding the complications of the newborn. High rates of prematurity, low birth weight, failure to thrive, sudden infant death syndrome, crib death, which occurs at about a 10 times increased rate in infants whose mothers have used drugs. However, if you look at all of the drugs and analyze the data, the one drug that is most dangerous, that is, it has the highest predictive effect for resulting in SIDS, that one drug is tobacco. And in fact, even if a woman doesn't smoke during pregnancy, but a baby is born into the family and someone in the family is smoking, the rate of SIDS goes up. And so, again, tobacco is a drug of abuse. And this gets into the secondhand smoke issue, which is a whole other issue that we talk about with groups sometimes, about the impact of secondhand smoke. And then dysmorphology. And this is a good example. This is a baby whose mother used cocaine during pregnancy. The baby was born at term. And what you can see is that the baby was born missing her middle fingers on her right hand. What this is an example of is something called limb reduction deformity. The mother was using cocaine. Cocaine crossed the placenta and caused dopamine levels to go high in the fetus. And the dopamine circulated and caused constriction of various blood vessels, including the blood vessels, the arteries leading to the middle 2 fingers of this hand. And so those fingers died because these blood vessels, these arteries constricted down. And this is called a limb reduction deformity. Now, this baby also was born missing actually little girl, her left kidney, had no uterus, and had no colon. They had all infarcted. And so she had to have a colostomy. This is an animal study that demonstrates the same thing. This is a rat fetus. The mother was given cocaine, and 24 hours later, the fetus was delivered, and you can see the vascular damage in the extremities. Now, this is a methamphetamine exposed infant. The mother used meth all through pregnancy, and this is a myelomeningocele, which, as I'm sure you're aware, that's when a baby is born with his spinal cord sticking out of his back. And this is caused by a vascular disruption. And this is the front of that infant, and you can see the same kinds of limb reduction deformities in this infant as I showed you with the infant exposed to cocaine. And then finally, you can get direct central nervous system damage. This is an infant whose mother used cocaine during pregnancy, and the baby had a stroke in utero from the vasoconstriction of the cerebral arteries caused by the mother's cocaine use. The cocaine crossed the placenta, caused vasoconstriction, that is constriction of the cerebral arteries, so that part of the brain up in the upper left didn't have a blood supply, and the fetus had a stroke in utero. Now, those are the medical complications, and the physician's offices are going to be taking care of those kinds of issues. Your work in working with the home visitors and supporting them is really going to come down more to the neurobehavior of the infants, because even when the infants look perfectly normal physically, they have no medical complications from their prenatal exposure. They almost all will have neurobehavioral difficulties. And for our discussion today, the two most important areas of neurobehavioral difficulties are orientation and state regulation. Now, orientation is the ability of the newborn infant to orient toward a specific type of stimulus. So the way you can test this is stand on either side of the infant, and this is as early as 24 hours of age. Just talk to the infant softly, and you will see that he has alerting responses, and then will turn his eyes and maybe his whole head toward your voice. And go to the other side and have you or the mother talk to the infant, and the infant will orient toward the voice on the other side. In drug and alcohol exposed infants, when you talk to the infant, he will show alerting responses, but then he will not be able to orient toward your voice. That is, he won't be able to find where your voice is coming from. And if you keep talking to him, and in fact move into his line of vision, at 24 hours of age, a typical infant will be able to focus on your face. And if you move a bit from one side to the other side in the periphery, the infant will be able to follow you, even at 24 hours of age. But if an infant has been exposed to drugs or alcohol, when you try to capture his gaze, when you get there in front of him, what you'll see is the infant will instantly move away. He'll avert his gaze. We call this gaze aversion, because he can't tolerate your face. It's too overloading for him. Now, if you persist, and a lot of mothers will try to keep working to get their baby to orient toward them, to respond to them, and so they start overstimulating the infant, and the infant will begin to get overloaded. And as I'm sure you know, the first signs, the earliest signs of infant overload, of infant stress, are sneezing, yawning, and hiccuping. And again, here's something that you need to work with the home visitors on, is how to recognize an infant who's becoming stressed out. Because if you keep stimulating him, he's going to get completely overwhelmed, overloaded, will hit a crying state, and will be very hard to bring back down. And so you want to be able to teach the home visitors, to teach the mothers on how to recognize that early infant stress. If you don't, the baby will escalate very rapidly to a crying, irritable state. And this is where we get into the issues of state regulation, the ability to regulate state of arousal. And what you see in normal infants is a baby will be quiet and sleeping, will begin to awaken, will reach an alert, responsive state, and may even move past that into a crying state. But if you don't go into the infant, what he will do is exhibit self soothing behaviors. He'll rock his head side to side, he'll bring his hands and legs into the midline, and may even suck his hand, may rock his head. Those are all self soothing behaviors. But babies who have been exposed to drugs and alcohol prenatally have difficulty self-soothing. And so they reach very high, crying, irritable states and just as suddenly drop down to a deep sleep and then rebound suddenly up into crying again. And so they have very erratic states of arousal. And of course, that makes it very difficult to care for that infant. And so what you have to do is teach home visitors as to how to teach the mothers how to comfort that infant. And I'm sure all of you as infant mental health specialists know the strategies for comforting infants, but most importantly, you need to help the home visitors, help the mothers with recognizing early stress in the infants. That's key. And that's something that's often left out of the equation. So recognizing the infant who is yawning, sneezing, and hiccuping, teaching the mothers to step back and let the baby self-soothe. Now, why are these things happening in the infant? Well, you remember this previous model I showed you with the electrical stimulus moving down the pathway, dopamine picking it up, carried across, releasing it. And as we said, methamphetamine causes excess release of dopamine. Now, what I didn't tell you is what happens over time if a woman keeps using methamphetamine is you begin to deplete your dopamine receptors. So essentially, there's not enough dopamine over here. And the same thing happens with cocaine. So you release dopamine, carries it across, but as it comes back, remember, cocaine blocks dopamine reuptake. So over time, you deplete dopamine receptors. And that's the same thing that happens with nicotine smokers. Now, here's an adult. On your left, this is a PET scan. And what you see, we're looking from above. This is a normal PET scan, and the yellow and red is dopamine. That's what dopamine looks like on a PET scan. Now, this is that same individual on the right after a year of cocaine use. And what you can see is the yellow and red are gone. And what has happened over time in the adult is we have depleted the dopamine receptors because of the chronic cocaine use. This is the same thing that animal studies have shown that baby rats whose mothers use cocaine during pregnancy, if you do a PET scan on those baby rats at birth, you find they're born with depleted dopamine receptors. And the dopamine is never replenished. So adolescence, adulthood, they continue with inadequate dopamine receptors. So the receptors have been depleted. So the basis for the infants not being able to respond appropriately to their mothers or to be able to orient toward their mother's voices or respond to their mother's gaze is based on the fact that the prenatal drug exposure resulted in depleted dopamine receptors so that the infant is not able to regulate behavior appropriately. Now, over time, what we know is that babies exposed prenatally to drugs and alcohol, as they grow into early childhood and older, have neurodevelopmental difficulties related to these changes in the prefrontal cortex and the functioning of the regulatory system. And the three areas that most commonly are affected are executive functioning, self-regulation, and adaptive functioning. Executive functioning is the ability to plan and complete a task. It's related to memory, especially working memory. And I'm going to give you a working memory test right now. When I say go, what I want you to do is tell me your telephone number backwards. Ready? Go. What you did in order to recite your telephone number backwards is you had to visualize, some of you visualized the number and then literally read it off backwards. And that's if you're a visual learner, that's what you did. If you're an auditory learner, which I would think most of you as infant mental health specialists are really auditory learners, what you did is you recited your number forward, essentially memorizing it, and then were able to say it backwards. But that's all part of executive functioning. And if you had been exposed prenatally to drugs or alcohol, you would have difficulty with that task. The second area, self-regulation, is the ability to regulate your behaviors. And again, we've talked about that quite a bit. But this is why children with prenatal exposure show up with high rates of attention deficit and attention deficit hyperactivity disorder. In fact, the most recent studies show that about 74% of children with prenatal exposure meet criteria for ADHD. And the third area is adaptive functioning, the ability to use cognitive information to guide you in performing daily life skills. And a good example of that is I have many young people that I work with that are now adolescents, were prenatally exposed. Very bright. They can have an IQ of like 120. I have one young lady with an IQ of 125, but she can't tell time. She cannot read a clock, and even if it's a digital clock, she can read the time, but she has no concept of what that means. So if it's 3 o'clock in the afternoon, she cannot tell you how long it is until dinner time. So those are the three areas that are most affected. Now, to summarize this, if you look at children developmentally over time, children who have been exposed prenatally to drugs and alcohol, in the 0 to 3 population, the main problems are self-regulation. And this is when the children get into sleep problems, feeding problems, hyperactivity, and tantruming. And again, your job, one of the most common questions that I'm getting from the McVie home visitors, I had an email just the other day, a 2-year-old having a tantrum, and the young lady, the home visitor that emailed me said her own child has tantrums. So how does she know when the woman she's working with, when her baby is having tantrums, if that's normal or not? And of course, the advice is to look at frequency and duration. All 2-year-olds are going to have tantrums, but you have to ask how often are these tantrums occurring and how long do they last? So in the 0 to 3 population, you're going to be looking mainly at self-regulation and helping the home visitors work with their mothers on self-regulation in their infants. As they get toward the end of the 0 to 3 timeline, you'll begin seeing more and more difficulties with adaptive behaviors. And these really start showing up in the 3 to 6-year-olds. So the 3 to 6-year-olds not only have self-regulatory problems, but start having difficulties with impulsivity, safety, reading social cues. These are all things that a normal 3 to 6-year-old should be able to do. By school age, their neurocognitive difficulties kick in, such as with working memory. That was the test I just gave you with your telephone number. Attention problems, visual, spatial, math. And then, of course, as an adolescent, all of these come together and you get into the risk-taking, the novelty-seeking, issues in substance abuse, and sexual and legal issues. So this is just a way kind of an overview of how to look at the children's behaviors over time. So, what I've tried to do for you today is to give you an overview and an understanding of the reason for the behaviors that the home visitors might see in the women they're working with and in the infants, and especially in that relationship between the mother and infant. Thank you very much for attending today. It's our pleasure to work with all of you, and I look forward to another exciting year. Thank you.